Assalamu alaikum. Today I am going to discuss about PNH. PNH means paroxysmal nocturnal haemoglobinuria. PNH is an acquired hemopoietic stem cell disorder characterized by intravascular hemolysis, bone marrow failure, and thrombosis in unusual site. If a patient present with anemia, dark urine in the morning, and unexplained thrombosis in unusual site, that is liver or brain, then PNH should come into our mind. How PNH is present? PNH can present in different way, but we can read it in three headlines. Number one, isolated PNH. Number two, complication of PNH, that is thrombosis. And number three, marrow failure. If PNH present with isolated PNH, then it is hemolytic type. Features of intravascular hemolysis present here, that is dark urine, haemoglobinuria, anemia, jaundice, and fatigue. If patient present with PNH with thrombosis, it is very common. Thrombosis may be venous or arterial. Venous thrombosis is common. It can present with Budd-Chiari syndrome, portal vein thrombosis, CVST, and deep vein thrombosis. Clues to diagnosis of thrombosis is patient with abdominal pain, hepatomegaly, and ascites. The diagnosis is BCS, Budd-Chiari syndrome. If patient present with sudden severe headache with convulsion or seizure, then CVST should come into our mind. If patient present with unilateral leg swelling, then DVT is common. Arterial thrombosis is less common but serious. Arterial thrombosis may present with limb ischemia, MI, or stroke. Clues to diagnosis is acute limb pain, coldness, and clammy skin, and reduced pulse. Number 3. PNH with marrow failure. If PNH present with marrow failure, then there is two features. If PNH present with pancytopenia, then the diagnosis is either aplastic anemia or myelodysplastic syndrome. If there is high WBC count, then AML should come into our mind. Now investigation. For investigation, we should divide it at same way, three ways: for isolated PNH, for complication with PNH, and for marrow failure. For isolated PNH, investigation of hemolytic anemia, that is hemolytic workup, should be done. The hallmark of hemolysis, that is low hemoglobin, unconjugated bilirubin is high, LDH and reticulocyte is high. And for additional intravascular hemolysis, low haptoglobulin and haemoglobinuria is present. In hemolytic workup, investigation for thrombophilia is also needed. Flow cytometry is confirmatory. Absence of CD55 and CD59 is confirmatory in case of PNH. We should do another test, that is APS panel. Both primary and secondary screening, that is SLE, should be excluded, and protein C, protein S, and antithrombin 3 deficiency. Number 2, isolated PNH. After isolated PNH with complication, we should do ultrasonography with Doppler study to see hepatic vein and portal vein, MRV if we suspect CVST, CT angiogram, or Doppler study of limb if we suspect PVD. Number 3, PNH with marrow failure. We should do CBC with PVF if we found pancytopenia, then aplastic anemia in young patient and myelodysplastic syndrome in old patient should come into our mind. And if WBC count is high, then AML should come into our mind. After CBC with PVF, the next investigation is bone marrow. Treatment. Treatment consists of mainly 4 pillars. Number 1, supportive treatment. Supportive treatment is blood transfusion and folic acid supplement. Number 2, prophylaxis or treatment of thrombosis, that is anticoagulant therapy. Standard care with C5 monoclonal antibody, that is eculizumab. Before using eculizumab, Vaccination against Neisseria meningitis is needed. Number 4. Treatment of complication. If patient has Budd-Chiari syndrome, aplastic anemia, myelodysplastic syndrome, or ischemic spleen, then treatment of associated complication is needed. So, in brief, PNH is rare rare thrombotic disorder. We should always remember this point. Hemolysis with dark urine and thrombosis, PNH should come into our mind. Thrombosis in unusual site is a major clue in PNH. Flow cytometry is the gold standard diagnostic test, and eculizumab is the life-saving therapy. Thank you. Thank you all.